Thanks for joining this webinar. I'm Chinmay Achareka. I welcome you all on behalf of Hetero Healthcare family for the webinar on post-COVID complications, management options, current and newer perspectives. Patients do recover from COVID-19, but are grappled with post-COVID complications. And this webinar is all about that latter part. With this, let me introduce to our moderator of the webinar, Dr. Urman Dhruv. Dr. Dhruv is a MD, Internal Medicine, LLB, Senior Physician and Director at Department of Internal Medicine and Diabetes at CG Hospital, Ahmedabad. With this, I would hand over the session to Dr. Dhruv.
Good evening, everybody. Thanks, Hetero Healthcare, for arranging this webinar and inviting us all. I'll be sharing my screen. I hope I am audible and visible. What we are going to talk and our agenda would be this way. I'll have some sort of introductory slides about post-COVID syndrome, about a couple of minutes or 3 minutes. Then we'll introduce our speakers, and then we'll have 3 cases, each of 4 slides, and then we'll have some question answers. I'll request all those who are participating that this should not remain simply a lecture. Let it be converted into a dual talk or a dialogue where you also share your experiences, because COVID is something where nobody can be a master. So you can share your experiences, your feedback, your suggestions, your queries. We've got the 3 best eminent speakers whom I will introduce in due course of time. So let's begin. First, something about post-COVID syndrome. Let's know how all those things begin. How did it start? In fact, it started with a COVID-19 support group. It came out on a social media and they suggested that they are feeling abandoned, dismissed and brushed off. And all these things were taken as lightly as possible by medical faculty, I must admit. Nobody believed that there is something real matter in the talk that they are having on the social media, because everybody used to believe that COVID is a 15-day disease or a disease which ends ultimately in the hospital. Then there was a long COVID support group which came out and said that at the end of 3 months, 4 months, we are having chest pain, or we are having cough, or we are having breathlessness. Thousands and thousands of us have been struggling for weeks and months with ongoing symptoms of COVID-19. Then came the personal accounts, when Paul Garner came out and said that at the end of 7 weeks, I have a roller coaster of ill health. So did Nisrin Elwan. And when BMJ came out with these opinions, everybody had to take it little seriously. Then came this Guardian article. Till then, we were thinking that this is medical gaslighting. Then we gave a name long haul COVID. Then we came out with a terminology post-acute COVID. And now we have come with a terminology post-COVID syndrome. What did it cost? It cost 8 to 29 extra fatalities per 1,000. Remember, this is not a wrong spelling. This additional X is for these 8 to 29 per 1,000 deaths. 8 additional deaths at the end of 3 months in those who were not hospitalized, and 29 additional deaths in those who were hospitalized at the end of 3 months. And we, despite the fact that the second wave is over, we still see the deaths happening after the second wave. Italian study was the first to show that only 12% of the patients were completely devoid of symptoms at the end of 3 or 4 weeks. Then came rapid guidelines from WHO and also from Ministry of Health in India. The definition was given. Long COVID was defined as person with symptoms 3 or more weeks after COVID-19 onset. And those having symptoms more than 12 weeks were called chronic COVID. What were the basis for these long-term manifestations? It was reasonably to anticipate the manifestations, pulmonary, cardiovascular and neurological, which was something which was expected, but it spread a lot more than that. Then we realized that ACE2 receptors are there all across the body, more in extrapulmonary tissues than in pulmonary tissues. 6 months follow-up in SARS and MERS survivors also showed the problems. There was reduced DLCO, reduced exercise capacity, and then came post-traumatic stress disorders, depression, and anxiety. Extrapulmonary manifestations also started lasting along dermatology, cardiac, endocrine, GI, neurologic, thromboembolism, hepatic, and renal. Today what we are going to do is we are going to take only 3 complications. One regarding anticoagulation, second regarding antifibrotic drugs, third neurological complications. But we will touch few of the post-COVID persisting symptoms simultaneously during our question answer session. Italian data once again came and suggested that post-COVID-19 follow-up also showed that 32% had 1 to 2 persistent symptoms at the end of 60 weeks. Then came management of long COVID with medical management and self-management, which included diet, sleep, quitting smoking, limiting alcohol, and limiting caffeine, in addition to pulmonary rehabilitation, about which we'll have a talk. Then came the protocol, which we will be just touching at the end of the session. So, with this brief introduction, we'll go to our first case. But before that, let us introduce our panel of speakers, eminent speakers. Myself is Dr. Dhruv, then is Dr. Neil Thakkar, DTCT, TNB, EDAN from Paris, IDCCM Hinduja, Mumbai. He is a consultant intensivist, pulmonologist and critical care physician, Vadodara, Gujarat. We have got another pulmonologist. One is intensivist. We have got another pulmonologist, Dr. Kalpesh T. Panchal. He is MD with pulmonary medicine, gold medalist from BJ Medical College, and diploma in allergy and asthma from CMC. We are not going into the detailed biodata of each because it is their work or it is their speech or it is their answers or their performance which is going to speak. And then we got Dr. Manan Mehta, MDDM Neurology, consultant neurologist at Mehta Neurology Center, Vadodara and Tricolor Hospital. So 3 eminent speakers, Dr. Manan, Dr. Kalpesh and Dr. Neil. Right? So with the help of those 3, we are hoping to sail through this voyage of post-COVID complication. We'll start with case number 1. I'll give the brief introduction to the case. We are not going to discuss the case, but questions related to the case. 45-year-old male, practicing doctor, no comorbidity, fever low grade for 2 days and then high grade for 5 days. Breathlessness grade 1 on day 3, converted to grade 3 on day 6. Dry cough, RT-PCR positive on day 6. Sorry, RT-PCR positive, this is 6th day of RT-PCR positive. Oxygen saturation on admission 88, NL ratio 4:1, CRP rose from 7 to 22 on day 6, D-dimer rose from 250 to 950, renal liver function normal, non-diabetic, oxygen requirement was 12 liters at the time of admission. Once again, I remind all our delegates that we are not going to discuss the acute management. We are interested in post-COVID scenario. He did not tolerate HFNC, NIV with FiO2 80% he was posted on, and as usual, steroids with remdesivir was given. This is his baseline X-ray, baseline CT, which shows typical GGOs, and this was his X-ray on day 6. When one can see even on radiological examination on X-ray, there is extensive involvement of the lower lobes. He stayed in ICU for 19 days. RT-PCR became negative. As per protocol, TOSI was not given. 50% FiO2 to maintain SpO2 at 91 and shifted to post-COVID ICU. D-dimer never crossed 1000 during these 19 days, and this is little bit surprising because we generally don't see this. Steroids were continued, pulmonary rehab was started, oxygen requirement went down to 2 to 3 liters per minute. He was discharged on day 38th with steroids. He had breathlessness on exertion, low flow oxygen at home. CRP IL-6 not elevated, but on 30th day when he was discharged with steroids, his D-dimer rose to 2500. His 6-minute walk distance was 220 meters with 4 liters of oxygen per minute, desaturated to 78% on walking. These are his classical X-rays which shows marked fibrosis, and accordingly the drugs were started. So we'll stop here for the time being and we'll shift to our speakers one by one. So we'll start with Dr. Neil.
Yes.
Dr. Neil, what do you think? What are the common symptoms? Very common. We are not going to enumerate each, but what are the common symptoms that you've seen as a part of post-COVID syndrome?
So, sir, as you rightly, thank you so much for your kind introduction, sir. And as you have rightly pointed out earlier in your initial introduction, that post-COVID syndrome is more of symptoms which are persistent even later on. And in the post-COVID symptoms, the most common one we normally see is the breathlessness that we find in most of our patients that who have, like in our case, we've discussed there was extensive inflammatory involvement. Post that, there was also extensive fibrosis. So dyspnea with increased exertion, fatigue, cough, sometimes dry cough which persists, chest pain, non-specific myalgia or arthralgia, that is joint pains. Sometimes even generalized non-pulmonary symptoms such as extrapulmonary involvement. Then you will have abdominal pain, lightheadedness. There are mood changes. There are some behavioral changes also. So these are all, so as we say that post-COVID syndrome is not a single entity. It is a continuum of disease. That the disease itself is continuing even post-COVID. And it can be either due to the inflammatory damage, it can be due to the prothrombotic state, or based on the predominant pathophysiology involved in the disease, it could have an array of presentations post-discharge and for a long period of time that way.
Thank you. Thank you, Dr. Neil. I'll go to Dr. Kalpesh. Dr. Manan, you may not be involved for a long time in first 20-30 minutes, although we'll try to find out some neurological questions for you. But initially, we'll be staying with Dr. Kalpesh and Dr. Neil. So, Dr. Kalpesh, we used anticoagulants profoundly in first wave, little less in second wave. What's your experience with anticoagulants in first and second wave? Do you still believe that they completely changed the scenario in both the waves, or you were little less proactive using anticoagulants in second wave?
Thank you very much, sir, for your introduction. And before answering the question, your background picture is very good. We are expecting these locations since the start of COVID. So, back to our question, sir. So use of anticoagulants both in first wave and second wave. Yes, definitely. In first wave, we have a very less number of data available for use of anticoagulants in both OPD patients and indoor patients. But with time and with experience, we are using almost all type of anticoagulant agents in our practice. And based on my experience in first wave, I have used low molecular weight heparins and unfractionated heparins more over directly acting anticoagulants. But with end of first wave or after 3 to 6 months of first wave, we have started using directly acting anticoagulants. Before jumping directly towards that anticoagulants, I think we should also understand the mechanism of action of each anticoagulants. So before using it, I think that is also very important for treating physician or treating pulmonologist. Second wave, definitely, we know that due to shortage of beds and due to crisis situation, we have treated patients at COVID care centers, and we have treated patients at home also. Many patients require hospital setup, but that is not possible due to the pandemic situation. In that case, definitely we have used low molecular weight heparins at these setups also, along with adding of directly acting anticoagulants on at the time of discharge. So, if I am telling you my experience that I have used enoxaparin, unfractionated heparin, in few cases fondaparinux also, and in directly acting oral anticoagulants, I have used more of rivaroxaban and apixaban rather than dabigatran. In initial days, where we are using all three agents, I have used dabigatran also. If you,
I'll just enter here. Dr.
yes.
Kalpesh, what we want to know at present is, was there any difference in the use of anticoagulants in first wave and second wave?
Yes, sir, definitely. With more experience and with more follow-up of our first wave patients, we know that there are so many post-COVID thrombotic complications in post-COVID patients, particularly those patients who are in hospitals and in ICU setup for longer periods, and those patients who are on ventilator or BiPAP support. So, for prevention of that post-thrombotic complication, post-COVID complications, definitely in second wave, we are using more directly acting oral anticoagulants as compared to the first wave. And we are using for up to 4 to 6 weeks also.
Okay. Coming to Dr. Neil, what would be your indication for using parenteral or oral? Where will you use parenteral anticoagulation, and where will you use oral anticoagulation?
Thank you, sir. So basically, again, I will answer some portion of the last question where, sir, you had definitely asked what changes the outcome. So if whether anticoagulation changes the outcome or not. So that also has part relation to this one, that in between the waves and even during the last year, there is a lot of evidence. So there are two parts of any answer. One is evidence and one is experience. So evidence is that there were two big trials. One was the inspiration trial and one was the action trial. Inspiration trial was published somewhere in March and action trial was published somewhere in June of 2021. Now, both of these, what they did was they compared various anticoagulation strategies with respect to COVID-19, either low dose, intermediate dose, or maximum therapeutic dose anticoagulation. In the inspiration trial, they found that there was no significant benefit with higher dose COVID anticoagulation in hospitalized patients with respect to their morbidity and mortality. This is again not for proven venous thromboembolism patients. This is hospitalized COVID-19 patients with severe hypoxia. Same for in the action trial, in that trial they used rivaroxaban also as well as enoxaparin, and there again they were able to find that increasing the dose did not help with the morbidity or the outcome of the patients. However, there was more bleeding risk with the higher doses. So again, for usage of parenteral anticoagulants, as per the CDC and the FDA guidance, for any hospitalized patient with moderate to severe COVID-19 disease with definitive hypoxia, all these patients, there is definitely a role of parenteral anticoagulation, either in the form of low molecular weight heparin or the conventional unfractionated heparin. But we have to put them on a prophylactic dose of either. And if a patient has definitively proven diagnosed with either pulmonary embolism, venous thrombolism, or an arterial thrombi, in these cases, there is definitely a role of therapeutic anticoagulation, or even if we are using unfractionated heparin, then either in the infusion form. In the experience, like whatever we have seen in patients either with a proven or very likely that this patient has a pulmonary embolism, severe hypoxia, higher risk with a malignancy or a comorbidity with high D-dimers, and even in these cases when the probability of T is very likely, in these cases there is definitely a change in the outcome if we use the anticoagulation at the right time and the right dose. So again, these would be the patients where there is definitely a role of anticoagulation. Hospitalized hypoxic COVID patients, that would be the role of parenteral anticoagulation. For oral anticoagulation, again, we have to see that as there is limited data as to directly starting novel oral anticoagulation agents in hospitalized patients. Most of the times we start them on some form of parenteral mode and then switch it over to an oral mode prior to, like, when we are about to discharge the patient or in the hospital, if the patient as a prolonged stay definitive, oral anticoagulation agents can be used either in the form of conventional agents or the newer oral anticoagulation agents. So again, definitive from prothrombotic states is where we would be looking at oral anticoagulation agents. Thank you.
Okay, fine. So my question, I'll twist my question and put it to both the doctors. First to Dr. Kalpesh. Would you require a definite documentation of thromboembolism somewhere in the body, maybe deep vein, maybe pulmonary area, or somewhere else, for putting the patient or posting the patient on oral anticoagulant at the time of discharge, or you are satisfied with the D-dimer results only?
Definitely, at every point of time, we can't do all investigations at all setups, particularly in the small setup. In that cases, we can just prediction of thrombotic state of the patient and severity indicators and any future thrombotic sectors with our few scores available for that, like modified improved score and other scores are available for predicting the thrombosis in post-COVID patients. And based on that, we can, and along with the D-dimer values, we can start the oral anticoagulant. If the patient is having specific risk factors like obesity, age more than 60 years, prolonged immobilization in the ICUs, or previous history of any cancer, or previous history of any cardiac issues, previous history of any surgeries. In that cases, I think along with D-dimer value, if we can't do the CT pulmonary angiography or lower limb venous Doppler, but if these factors are present, then I think we should start oral anticoagulants at the time of discharge or in prolonged hospitalization state, where patient requires long-term oxygen support. And if there is complications arising from the parenteral low molecular weight, many times injection thrombosis or any other issues related to that, and more than 3 weeks of hospitalization, in that case, I think we can start taking new anticoagulants in a prophylactic dose, as Dr. Neil has said rightly, because many a times we have seen that with therapeutic dose, so many bleeding complications have occurred, and we are also encountered this kind of bleeding complications, GI bleedings, and so many perrectal bleedings. So in initial days, when we have not that much data and not that much experience, we are combining low molecular weight repairing with directly active oral anticoagulants. In that case, many patients have suffered from bleeding complications. So prophylactic doses we should start, and for therapeutic doses, if there is a specific risk factors and specific non-invasive investigations or invasive investigations showing the pulmonary thromboembolism or DVT, then we should start with therapeutic dose.
Coming to Dr. Neil, would you rely solely on thrombotic calculator, risk calculator, D-dimer, or would you give anticoagulation to all those who are hospitalized and all those who are discharged from the hospital, oral anticoagulation? So would it be general blanket protocol to give oral anticoagulant to all, or just to look for thrombotic risk, or just to depend upon D-dimer?
My specific answer to this would be that every patient is different. So we cannot have a blanket rule that every patient on discharge should receive some form of oral anticoagulation. We definitely have to individualize the therapy. A risk calculator, either the old modified Wells score or the newer modified improved score, as per Dr. Kalpesh, what he had mentioned, either a history of embolism or a malignancy, prolonged ICU stay, immobilization, or an age more than 60. These are all risk factors which can pinpoint a particular population where we need to give some anticoagulation. Coming to evidence, the FDA has approved, after the recommendation of American Society of Hematology in February, that for any patient, number one, with a documented venous thromboembolism, minimum 3 months of oral anticoagulation is needed at home, in the form of either a directly acting newer agent or a conventional agent. And for patients where there is a high probability, there is a recommendation by the FDA regarding rivaroxaban also as a NOAC. That rivaroxaban given for 10 milligram daily for a period of around 30 to 40 days has been recommended since February by the FDA for hospitalized COVID patients with a higher modified improved score, and with that a combination of D-dimer. So that would give us a very good subset. This score is now validated, the modified improved VTE risk score. So these are some tools which can help in identifying these patients. I would not be supportive of a blanket therapy of oral anticoagulation agents.
So all in all, we agree that hospitalized patient with high thrombotic risk should be posted on prophylactic sub-Q low molecular weight heparin, and they should be prescribed the oral anticoagulant at the time of discharge with a look at the bleeding risk calculator also. That's right. Before I come back to you, either of them, I'll like to include Dr. Manan. Dr. Manan, we all physicians go on prescribing oral anticoagulant, and the penalty is paid by the patient and they reach you. So how many hemorrhagic strokes do you believe were attributed to the treatment of COVID in last 1 year in your practice?
Okay, thank you very much, sir, and finally happy to speak. I'll just tell you a small thing that before COVID, when you used to give anticoagulation for non-valvular atrial fibrillation or for rheumatic heart disease, now we are always scared. Okay, how is the bleeding risk and what will happen to such patients? So our professors used to laugh that if the stroke happens, that it is God given, and if a hemorrhage happens, it is doctor given. So, coming to your valid question is, yes, see, prophylactic anticoagulation from a neurology perspective, there is no role of prophylactic anticoagulation just to prevent a stroke. As in comparison, when there is a high risk, of course, we know whether there is a patient of pulmonary embolism in the past, if he is having DVT, or he is having some high risk factors of procoagulation state. Now, I have seen at least 6 to 7 patients who come with a small bleed, and one patient came with a large bleed, and we had to decompress that patient, and unfortunately that patient succumbed. And this was all due to oral anticoagulation on discharge, or excessive use of anticoagulation LMWH in intra-hospital within the hospital and during the COVID treatment. But having said that, it is not about to give or not to give. The point to be taken here is that a judicious use, and specifically only when on indicated patients. Now, you asked one question that first wave and second wave use of anticoagulation. Now it is proven slightly beyond doubt that we have during the second wave there was more judicious use of anticoagulation.
Exactly.
Yes, because two main reasons. Because we came to know that number one, we had better molecules to treat. Now we know that tocilizumab was having no role majorly, and remdesivir as well as some other steroids, they were the game changers. And in such cases, the use of anticoagulation was less because they were treated early and they were treated properly with better clarity of guidelines.
So in other words, perfect.
Yes,
so in other words, we all agree that during first wave or during the initial part of second wave, we went on giving oral anticoagulant to practically every patient, thinking that it is a game changer. But by the middle of the second wave, we realized that anticoagulation is not for all. It is not that safe. Okay, coming to once again to Dr. Kalpesh. Out of 3 oral anticoagulants that are available, which do you think is safer and more efficacious, or all of them are same as per your experience? And then we'll have opinion of Dr. Neil also.
Okay. So that question is for oral anticoagulants, not parenteral. Only oral.
Yeah, oral.
So for oral anticoagulants, we have 3 newer and 1 vitamin K antagonist. But we are not using that molecule, and we have not used that molecule in COVID scenario because of regular monitoring of PT-INR and everything. But yes, definitely, as Dr. Manan has said, in second wave, we have used the directly acting anticoagulants judiciously. So out of 3 molecules, if the mechanism of action of apixaban and rivaroxaban is almost same, both are factor 10A inhibitors, and dabigatran has slightly different action. It is a direct inhibitor. So if we consider with reversal agent available, then yes, it is available only for dabigatran only in India. Rest of 2 molecules, there is no reversible agent available in India. Considering its efficacy and our experience in second wave, yes, rivaroxaban and apixaban we have used more often than dabigatran. All three molecules are equally efficacious. With dosage, I think rivaroxaban is more convenient for the patient, 10 milligram once a daily. And with apixaban, it is need to be given twice in a day, 2.5 milligram. But if the patient is suffering from any renal issues or any end-stage renal disease, these patients, I think in that patients, apixaban is indicated rather than rivaroxaban. Out of all three agents, apixaban and rivaroxaban is the choice of agents for all doctors in post-COVID or during COVID, during second wave.
Coming to Dr. Neil, preference for any of one molecule?
Thank you, sir. So again, coming back to there, I'll come to where one specific oral anticoagulant, newer one. But again, there is a role. Even I will just answer this as that again, every patient is not the same. So again, the conventional warfarin also has some role when there is a definitive post-COVID thrombus. So we had a lot of patients who were stuck in the hospital for a long period of time, either with a patient having a thrombus in one of the chambers of the heart, or in a pulmonary embolism, or a thrombus. In such cases, we are using low molecular weight heparin. Now, in such cases, when we overlap with a novel oral anticoagulation agent, there is no way we can quantify the anticoagulation or the level of blood thinning which is happening. With warfarin, with an overlap of heparin, there is a possibility that we can quantify when we have a target INR, some parameter which we can monitor for the anticoagulation. So warfarin is definitely not completely out. There is still a subset of patients where it is going to help when we have to achieve a degree of anticoagulation without increasing the risk of bleeding. Coming to among the novel oral anticoagulation agents, again, there is no prospective good results of randomized trials which have been published, which can compare the different novel oral anticoagulation agents. But we have to again see at the patient profile. There are patients, as besides the calculators, there are patients who are definitely at a risk of more bleeding, such as a patient with an active peptic ulcer disease, with thrombocytopenia, with a cancer, with a liver disease. So these are all patients who have a higher risk of bleeding. So in such cases, we definitely want to give an agent. Suppose we give that agent and we have to reverse it, we should have an agent that can reverse it. So among the molecules, as Dr. Kalpesh rightly said, that dabigatran is the only one which has a reversal agent. Second, if the patient has any renal problems or a renal failure, then in such cases, again, rivaroxaban, we have to give it with caution, because if the create clearance is very less, then that can aggravate the renal problem. So in those patients, we would definitely either give the other apixaban or dabigatran in such cases compared to rivaroxaban. So again, there is no dictum that this agent is for a blanket therapy. It has a personalized individual choice based on the patient and the disease. Thank you, sir.
Fine. So overall, once again, we agree that apixaban and rivaroxaban can be used, but the EGFR has to be thought about, and if EGFR is less than 30, then rivaroxaban is better avoided. Reversal agent is not available. Once a day convenience is definitely there, but that is not a very big plus point with that agent. And as Dr. Neil rightly said, you can always think about warfarin also, at least in hospitalized patient with documented thrombosis. Coming to Dr. Manan, I'm sorry, I forgot the name. Dr. Manan,
Yes,
you said you saw about 7-10 hemorrhagic strokes, which seems to be very small looking to the amount of anticoagulation that have been done in Baroda throughout the last 1 year. But did you find any one particular agent at culprit, or it was a generalized distribution?
Usually, CNS hemorrhages which I saw were all on conventional LMWH. They were not as in the patient going home and taking oral anticoagulation and coming back after 6-7 weeks or something like that. But one patient had some minor bleeding. That was actually he was admitted for 2 days and he was discharged also. As again, sir, advantages of a directly acting oral anticoagulant would be that ease of dosing, the less of monitoring, less of interactions, because post-COVID, lot of drugs, especially your antifungal drugs or your steroids or your many drugs, your theophylline group of drugs, they have a lot of interaction with your conventional warfarin and acetone. So that is slightly edge in the directly oral anticoagulation. As always, as we discussed, I prefer for all my patients who are having stroke for 3 months of anticoagulation. My experience is vast with rivaroxaban. In one patient only, we tried apixaban because of low, slightly high 1.9 creatinine. But rivaroxaban, I'm happy with the results.
So, all in all, before we close down the anticoagulation talk, we can come out with certain suggestions for the third wave. Hospitalized patient, parenteral anticoagulation is preferred, especially if you look at the thrombotic risk calculator at the time of discharge. The prophylactic oral anticoagulation may be prescribed if there is a high thrombotic risk, but at that time always look for the bleeding risk also, and if both are same, don't give unless you have really documented the thromboembolism somewhere. And newer oral anticoagulants are definitely better because most of the time the bleeding risk is much less than the warfarin or the conventional drugs. That's about it. Before we go on to antifibrotic drug, one more question for both our intensivist and pulmonologist. What are the pitfalls of D-dimer? Dr. Neil, do you feel there are certain pitfalls for D-dimer? As brief as possible.
Sure, sir. Thank you so much. So D-dimer again is been right and left probably the most. There is a pandemic blood test which we can say has been the D-dimer, the way it has been prescribed. So again, D-dimer has a lot of false positives also. Considering that COVID patients who are very sick or critical, they are patients where there will be a lot of inflammation. There will be ongoing inflammation, which itself causes a rise in the D-dimer. A lot of patients who have been on steroids, on immunomodulators, develop secondary infections, again, which can cause a rise in D-dimers. If any background history of trauma, malignancy, these are all other causes where D-dimer can increase. So D-dimer had a role before in the pre-COVID era, where D-dimer was the predominant, the good role was a negative predictive value. That in cases with either a pulmonary embolism or any prothrombotic stroke or any other way where we are suspecting it, it helped in ruling out. So again, even with COVID, the role of D-dimer helps with the negative predictive value rather than 100% ascertaining that this patient has a prothrombotic problem. So negative D-dimer has more value than a positive D-dimer. And again, false negatives are also seen with the D-dimer report if the patient's symptoms are persistent for beyond more than a week, or if the pulmonary embolism is very small or segmental embolism. And again, where the type of the D-dimer test, if a latex fixation test is used, these are all causes of false negative D-dimer. So we should definitely see D-dimer, but not in isolation with the clinical condition of the patient. Thank you, sir.
Dr. Kalpesh, would you like to add anything?
Yes, Dr. Neil has rightly said that D-dimer has a good negative predictive value rather than positive predictive. And in pre-COVID era, we are using D-dimer to rule out the pulmonary embolism or other thrombotic state. As if I tell you that when we are studying in a residency or in our post-graduation residency year, that even a single prick increase the D-dimer. If patient has an intracranial insertion for any antibiotic, that can also increase the D-dimer. So many central venous lines, so many capital lines, so many blood collections, so many things can increase the D-dimer. It is not only thrombotic marker, it is also inflammatory marker. So D-dimer can increase in so many states, even in pregnancy also. So I think in pregnancy, D-dimer is elevated rather than in normal. I think we should use lower in very few selected patients. particularly pregnant patients.
Okay, coming to the last question before we go on to second case, I'll go to Dr. Nil. We believe that, or it is being said, not I believe, but it is being said that the pediatric population would be more in abundance affected probably by third wave. Not sure whether it is true or not. But would D-dimer be an important investigation, or we cannot rely upon D-dimer in pediatric age group?
Thank you for the question, sir. So basically, again, the reason why we are thinking that in the third wave, pediatric population will be among the highest infected is because they are the ones where the majority is still unvaccinated. So when you are not vaccinated, that makes them more prone to develop any sort of a moderate to severe disease in the third wave, especially from the variant mutated COVID strains. So now why is there prothrombosis in COVID? So there are different strains. There is a mutation in the receptor binding protein, which causes different variations. And that inflammatory cascade creates a prothrombotic state. So now, again, in pediatric population, definitely if a patient has a multisystemic inflammatory syndrome of children, MISC as we call it, in that state also there is a rise in the D-dimer, which should definitely be taken as with that if a patient is hypoxic on oxygen with high fever, with raised inflammatory markers, that would be definitely a subset where we would want to give prophylactic dose anticoagulation based on the patient's weight. But again, we should not be jumping to therapeutic doses, especially in patients who are not hypoxic. We should give them weight-based prophylactic anticoagulation to hospitalized hypoxic patients of MISC. That is the subset where, again, D-dimer would have a role in probably with the patient's clinical condition and risk profile, where we will use D-dimer to judge our anticoagulation. Thank you, sir.
Perfect. So, unlike pregnancy, in pediatric population, D-dimer would be required to be performed and to correlate it with the clinical situation of the patient. We'll go to the second case now, very quickly. 54-year-old lady, housewife, hypothyroid, no other comorbidity. On 31st March 2021, presented with sore throat and myalgia for 5 days and dyspnea, grade 3 for 2 days with dry cough. Obviously,
your voice is not audible.
Hello, am I audible now?
Yes.
So 54-year-old lady, housewife, hypothyroidism, no other comorbidities. 31st March 2021 presented with sinus tachycardia, myalgia for 5 days and dyspnea grade 3 for 2 days with dry cough, positive RT-PCR. That's a typical patient that we see. Hospitalized with vital data, tachycardia, normal blood pressure, tachypnea, SpO2 at room air 80%, suggesting it's a severe COVID as per definition. And this was our EBG where PO2 was 66 with normal bicarb. Oxygen 12 liters requirement, steroids, remdesivir, antibiotics as usual. Second week, patient had new onset of fever with increased oxygen requirement. Secondary infection was ruled out. Gradually, she improved by 16th day and discharged with 6-minute walk distance of 200 meters. Loss of taste and severe fatigue. She was off oxygen at the time of discharge and steroids were also stopped. On follow-up at 23rd day, her 6-minute walk distance went down to 100. She got desaturated on walking 100 meters. She had weight gain of 8 kgs within last 20 days. Her HRCT showed intralobular and interlobular septal thickening. Steroids and antifibrotics were started. She had difficulty in getting up and shoulder weakness, proximal muscles, and severe snoring. Polysomnography was done, suggestive of moderate OSA. CPAP was started. Nausea and heartburns, LFT were okay. Steroids were stopped, CPAP continued, rehabilitation, antifibrotic were continued till date. Dyspnea went down to grade 1, CT improved. So that is about it. Before I go on to my first two speakers, I'll go to Dr. Manan.
Yes,
Let's presume that we have ruled out fever, CSF was normal. Patient had proximal vascular weakness, probably because of steroids. So coming to you, steroid-induced neurological symptoms. How often did you encounter and what were they?
Yes, sir. Sir, steroid-induced neurological symptoms, mainly the most common which I encountered is proximal muscle weakness because of prolonged steroids, and the patient is in catabolic state where there is a protein energy nutrition deficiency. Patient is on multiple antibiotics with neuromuscular antibiotics like colistin or your fluoroquinolones or your aminoglycosides, which are adding to the brunt of injury. So number one would be steroid-induced myopathy. Second, a critical illness myoneuropathy. So that is also very common, especially with the pro-inflammatory state and multiple drugs and prolonged steroid. This is a common where many a times we have difficulty in weaning off the patient from ventilator on in intubated patients also. Third would be an acute steroid encephalopathy, which is a very rare complication. But once one patient we saw that there was an encephalopathy, we could not diagnose anything, and we just stopped the steroid, and then the encephalopathy induced. It is reported in literature, but it is very rare. So predominantly neuromuscular weakness, whereas myopathy as well as critical illness myoneuropathy. These are the two main common causes to neurological symptoms for prolonged steroid use.
Okay, before going back to my two speakers, once second, Dr. Manan, what about steroids-induced psychiatric symptoms?
Yes,
There's a
that is
question
what.
already there.
Yes, that is what I'm saying. Steroid encephalopathy. It is rare. It is documented also, and it is just like any viral encephalopathy. We have seen such cases in steroid causing encephalopathy in COVID patients also. And on the contrary, there is also something called a steroid responsive encephalopathy, just like what we see in Hashimoto's disorders, where just viral encephalopathy, and we give pulse methylprednisolone for 3 days, and patient has some improvement in encephalopathy. The cause of steroid-induced psychosis is less, as in the prevalence is less, but we do see such cases, sir.
Okay, did you see a lot of euphoria with steroids?
Yes, long term, yes.
Yeah. Okay. Now we'll be back with our two doctors. So, Dr. Kalpesh Pai, before we go on to antifibrotic drugs, steroids as antifibrotic drugs, do they have any preventive role in prevention of fibrosis, lung fibrosis, number one? And when would you stop steroids in a case of COVID-19 pneumonia?
Okay. So, thank you, sir, for your question. Yes, steroids definitely can help along with antifibrotics, but yes, we should do it very cautiously because, as we have discussed, that steroid has so many side effects. We are using antifibrotics particularly in that group of patients. Those have a progressive dyspnea, low hospitalization, or those patients whose HRCT showing traction bronchiectasis or interlocular septal thickening. So many of the patients also showing ground glass opacities till the end of first month or second. Even I have seen ground glass opacities along with fibrotic changes in third month also. So yes, definitely ongoing inflammation is also very important because that is responsible for post-COVID interstitial lung disease. So many factors responsible for post-COVID interstitial lung disease like strong inflammation, elevated inflammatory markers, or prolonged oxygen therapy, ventilator-induced lung injuries, some medications, maybe remdesivir, steroids also responsible for developing fibrosis. So, based on the clinical condition, HRCT finding and pulmonary function test, in initial 4 to 6 weeks, we can start low dose steroids along with antifibrotics, but it is a case by case scenario. It is different. It is not a blanket therapy for all patients. It is used selectively, and also need to closely monitor the side effects of steroids. if we are prescribing along with antibiotics. But yes, many doctors and a few papers are also showing steroids, low dose steroids along with antibiotics. It is used as an antibiotic also.
Dr. Kalpesh, my question was, once again, I'll be back with my question. You rightly enumerated the risk factors for the patient who are likely to develop pulmonary fibrosis. Would you continue long-term steroids from the beginning in this group of patients? There is a group of patients that you enumerated. Would you continue steroids, or you will stop steroids, wait for fibrosis to occur and then go for steroids again?
No, sir, I will continue the steroids. I will continue the steroids up to 4 to 6 weeks in tapering doses, and I will do a close follow-up of the patient, need CT scan and lung function testing, also 6 weeks walk distance.
Dr. Neil, the same questions to you. Steroids in a very high-risk group of patients, would you continue for 4 to 6 weeks to prevent fibrosis, or would you give a very short course of steroids and then look for fibrosis to occur?
Sir, I would not give a long course to all high-risk patients. Whatever evidence and whatever data is there till now, recovery trial, med-COVID trial, all have shown that steroids can be given. They have a particular role, but blanket, like if we are giving to all, suppose only based on ground glassing, most of the patients with moderate to severe COVID pneumonia will have significant ground glassing. If the patients are hypoxic, if the patient require oxygen persistently, then there has to be a very judicious use of steroids after ruling out a secondary infection that we may have to make sure, because at present we saw another mucor epidemic after the COVID pandemic. So at that time, we have to make sure that when we are treating, there has to be minimal is better, less is more. So we don't want that we induce other problems in the patient by causing a risk of a secondary infection. So decision regarding steroids has to be very judicious. We have to make sure there is no infection. If the patient has long-term oxygen therapy, then a short judicious course of steroids after ruling out a secondary infection would be the way to go. In literature, the American Thoracic Society in May last couple of months back, they published one document, which is an analysis of a number of observational studies where they have studied steroids for post-COVID persistent ILD patients. The maximum duration of steroids they've used here is for a period of 4 weeks. And at that time, they have again tapered from the first week onwards. Rapid and aggressive tapering of prednisolone was done in that particular one study. Otherwise, major trials do not support usage of steroids to prevent fibrosis. They have a role in the cytokine storm. They definitely have a role to reduce inflammation, but not long-term steroids. If definitely a patient has post-COVID early fibrotic changes, we would want to limit that. If the patient has as in your case, the patient was hypoxic, there is significant 6-minute walk test limitations. So we have to compare that. Then a very small subset of patients where we would want to give a long-term steroid in such cases. And
okay. So that's an important message about anticoagulation and steroids. Both of them may be game changer, but they have to be used very judiciously, and steroids definitely for short term to begin with, because steroids are anti-inflammatory as far as COVID pneumonia is concerned and not anti-fibrotic or can prevent fibrosis. That's number one. Now coming to the COVID-induced lung fibrosis. First, I'll go to Dr. Neil. How do you diagnose? How do you stamp that a patient has COVID-induced fibrosis? Because there are certain trials of antifibrotic drugs as early as 14 days. So would you start antifibrotic drug on 14 days to prevent fibrosis, or you would have a pakka diagnosis of fibrosis, pulmonary fibrosis, through to serial CTs and then associate it with clinical condition and then start antifibrotic drugs?
Thank you, sir. So again, we have to go back to the first initial slide, which sir had shown, that what is long COVID syndrome itself. That the definition of long COVID, which has evolved over a period of time, is for symptoms which are persisting at least for 12 weeks or after. So there is definitely, if a patient is hospitalized, is remaining hypoxic, there is ground glassing, those are not probably the patients where we would want to start the steroids immediately. If the patient definitely has
antifibrotic. We are
Yes,
talking about
antifibrotic only, sir. Suppose a patient has only ground glassing, is hypoxic, there is inflammation. That is the time when steroid can be used, but not role of antifibrotic. For antifibrotics, we have to make sure that the patient, we give the lungs some time. There is reversible. There is a portion of fibrosis which is reversible. Like even in the COVID cases, when we observe them for a period of 3 months, in observational data as well as whatever patients we see, a lot of them there is regression of those radiological opacities. Not all of them go to the level of honeycombing. There are some with just septal thickening. There are some with just some changes which regress over a period of time. So antifibrotics, whenever we start, again, it is not a magic drug that we give it the next day, the antifibrotics the mechanism will start. It starts, but it's a gradual process. Whatever trials were done, the ASCEND trial, the capacity trial, the impulses trial, whatever were done on antifibrotic agents, all of them were long-term studies. Antifibrosis or control of fibrosis takes a long period of time. So before we start off any drug to do the same, we have to allow the body itself to also try to recover from the acute injury. So I would definitely start probably say around at least from the initial period of onset, if the patient has crossed the period of around 1 to 2 months. After that, there is persistent radiologic opacities, persistent oxygen, exertional oxygen requirement, exertional desaturation, limitation in the 6-minute walk test. That would be the right time to start the antifibrotic. This is based on evidence alone. And we should definitely follow whatever evidence possible when we are treating post-COVID ILD cases. Thank you, sir.
Perfect. Coming to Dr. Kalpesh, suppose everything is in favor of starting antifibrotic drug. There are 2 antifibrotic drugs that are available at present. Your choice, why, and what are the side effects of each, and how do you determine the doses?
Okay, so we have used the 2 antibiotic agents since I think before COVID era also. In our routine ILD patients or IPF patients or progressing fibrotic lung disease patients, we are using pirfenidone. And nintedanib was not available at that time because this was not approved. And in the second wave, so many cheaper options are available for nintedanib. So we have started using it. But before, I think I was part of one study or short study that is a study of nintedanib. So that is very few, I think 10 to 15 patients was enrolled. That is a study that was IPS patients of using of nintedanib. So at that time, we have seen very good experience, good improvement and very good compliance. So if we have a choice of both agents, pirfenidone and nintedanib. The issue with pirfenidone is we need to start first in a low dose and then based on the compliance and based on the side effect, based on the side effect or based on the compliance, we are increasing the dose up to the 2400 milligram. Initially, we are starting 200 milligram per day and then weekly or twice a week. We are increasing the dose up to 2400 milligram. But as we discussed, that this post-COVID interstitial lung disease is slightly different from that or diffuse fibrotic lung disease. So we are treating those patients before COVID era that is also that already have developed fibrosis. But in post-COVID, post-COVID ILD is different from that cases. In that case, we can prevent the development of fibrosis or we can reverse the fibrosis. So that is the advantage and that is the perfect time. If we intervene and we can, if we start the dose in a proper therapeutic range, then definitely the result is very good. Nintedanib is preferable over pirfenidone over 2 ways. First is the dosage, only 2 tablets in a day. That is the first advantage. Second advantage, we are directly starting in the therapeutic dose. We are not starting in the low dose. We are directly starting in the therapeutic dose. Third advantage is intervening is acting on so many factors like it is acting on transporting growth factor beta and other vascular and growth factors. There's so many factors it is acting. That is the reason the vitamin is more useful than perchlorate. But yes, we have a good rich experience of perchlorate since last at least 10 to 12 years, and both are equally efficacious molecules. Side effect profile, yes, with perchlorate we did both we need to monitor the liver function test. And particularly if we are discussing for nintedanib, diarrhea is the complaint. Many patients have complained of diarrhea in initial 1 week to 10 days. So in COVID era, where our patients are oxygen dependent, or where we have a prolonged hospitalization of at least 1 month or 3 weeks, more than 3 weeks. In that case, where the time is very important, we can't wait for 4 weeks. We can't wait for 4 weeks for having to reach the therapeutic dose of perchlorate. In that case, I think nintedanib is a drug of choice in COVID era, not in our routine IPF or DPLD patients.
Okay, coming to Dr. Neil, 3 things. COVID-induced fibrosis cannot regress. It can be simply, you can simply prevent the progression or the worsening, or you can halt it. Is it right or wrong with the help of antifibrotic drugs?
Sir, again, like I had mentioned in the last question, that there is very much a reversible component of the fibrosis, which has been not only studied in autopsy studies, there is also radiologic studies over a period of time.
Just a minute. Yes, just a minute. My question is, once you confirm that the reversibility is over, or without antifibrotic drug, starting antifibrotic drug, can they reverse the fibrosis, or they can simply prevent the worsening of fibrosis?
So here again the role is again for controlling the progression. From whatever studies, again the majority of data we have is pre-COVID. With perfenidone, we had the capacity in the ASCEND trial. With nintedanib, we had the Impulses 1 and the Impulses 2 trial. Now, why these data are important is because COVID has happened over the last couple of years. These all data are of decades of patients and decades of studies that we have found that there is a role of these antifibrotic agents, and again, more strong evidence is with perfenidone. That whatever we prescribe among the 2 antifibrotics, more evidence is with perfenidone. And just one more point to add to what Dr. Kalpesh had said regarding nintedanib, that with the side effect profile, that in nintedanib there was a concern which was published in the Lancet Respiratory Medicine, that with nintedanib, especially with a prothrombotic state, that we have patients who are on therapeutic doses of anticoagulation or with definitive thrombotic state, there is a risk of increased bleeding if a patient is on a therapeutic dose of anticoagulation and is prescribed nintedanib with that particular anticoagulation agent use. So this is one of the recent concerns which has been raised with respect to nintedanib. Diarrhea is definitely one of the other complications. But again, as sir has asked me, the role would be to control the progression and not to reverse the changes already done.
Okay, coming to Dr. Neil again. We'll be now having very short answers so that we can include more questions, and we can also give some role to our neurologist also. So in very brief, do you believe that the idea of launching or initiating antifibrotic drug very early was, why not to start it when fibrosis has not occurred rather than once the fibrosis has established, because they cannot reverse the fibrosis? So there were a couple of trials where they started it on 14th day. Should we start or not? Yes or no?
Sir, again, those are the trials which we are awaiting the results on, that whether there is any early role. But comparing it, just if we see the theoretic role, or if we compare based on the theoretic involvement, Now, what, as Dr. Kalpesh had rightly pointed out, there is a difference between both the drugs on the growth factors. Now, as the platelet-derived growth factor as well as the vascular endothelial growth factor, nintedanib inhibits both of these. But again, with respect to the major fibrotic molecule, that is TGF-beta, there is a role in the for pirfenidone, it inhibits TGF-beta throughout. For nintedanib, it only inhibits some portions or some subclasses of TGF-beta. So there is even if we start these drugs early, again I'm saying that the onset of these drugs action will only take a minimum period of a month before they act their effect as an anti-fibrotic to control the progression. So again, we would want strong literature, because as I said, with steroids, be it with anticoagulation, be it with antifibrotics, we should be treating something where there is a outcome difference, or we should not be aggravating a problem which is not there. So in cases, suppose we are starting an antifibrotic drug, there is the cost factor, there is the side effect profile, there are the drug interactions. So we have to make sure that it is definitely indicated, and we should not be in a hurry to start with antifibrotic agents.
So early initiation is not advisable. Dr. Kalpesh, now give me exactly 3 or 4 sentences absolute indication where you will start antifibrotic drug to a patient. We know that he belongs to a high risk for development of fibrosis. Now, which would be 3 or 4 indications where you will start antifibrotic drugs?
Okay. So, as Dr. Neil has rightly said, at the end of 2 weeks, when we have a patient in our hospital setup or at the home setup, where clinical improvement is not there, and radiological worsening in the form of septal thickening, in the form of traction bronchitis, along with ground capacity, and with high probability of developing fibrosis, is the main indication, and that is better judged by clinician. I think there is no thing to judge whether this patient is going into fibrosis or this patient is not going into fibrosis. Many times we have seen that at the time of admission, the score is 20 by 25, and at the time of discharge, patient is absolutely stable. So, and that patient doesn't need the antifibrotic infusion. And many times, at the time of admission, the patient severity score is very low, and during hospitalization period, he develops cytokine storms and prolonged hospitalization. So I think if you are asking me for 3 indications, the first indication, prolonged hospitalization, along with obesity and other comorbid conditions, that patients are high risk for developing the post-COVID interstitial lung disease pattern. Second thing, those patients who have developed the cytokine storm, or those patients have elevated inflammatory markers during their hospital course. I think
Dr. Kalpesh, we are not enumerating high-risk patients. At what stage, suppose a patient has come to you and you see the 1, 2, 3, and 4 things, I'll start antifibrotic drugs.
Many a times, sir, it is very difficult to judge at a single point of time. We need to monitor closely the patient. Many a times, patient refer for us for just opinion, second opinion. So in that case, we need more investigations in the form of good quality HRCT and if available, pulmonary function test. So clinical judgment is very important. Those patients, those who are oxygen support, exertional dyspnea, no improvement in 6-minute walk distance, I think those patients are right candidates to start antifibrotics, along with radiological worsening or radiological markers showing changes of IRD. I think that yes.
So if a physician wants some indication for antifibrotic drug, can we say at the end of 4 or 6 weeks, patient's walk distance is going down, oxygen requirement is not improving, and his CT scan is showing worsening on 2 consecutive cases, along with his clinical situation? That's probably a time. Now coming to the last part of the story, I'll go to Dr. Neil.
Go ahead. One point here regarding the radiology. So with regards to reversible and irreversible fibrosis, there has been, just because since we are discussing the CT scans, so basically there was a paper in thorax recently which showed that comparing the reversible to the irreversible state, one of the signs they had studied was the airways. Now again, there is an interstitial disease where normally the airways taper off. There's a larger airway, it goes down to a smaller airway. There is tapering of airways. So with irreversible fibrosis, or probably the time where the patient will require some form of antifibrotic therapy, there will be non-tapering of these airways. They are also termed as varicose airways. So that is also one specific subset in the scan, that there is non-tapering of the airways. That also defines a time when there is definitely a role of antifibrotic therapy with the septal thickening, honeycombing, rest of the signs. Thank you, sir.
Perfect. So we agree that with these symptoms we will start. Now, very briefly, importance of 6-minute walk distance for a physician in COVID. Dr. Neil, very brief. Please be brief.
Yes, sir. Thank you. I'll try to be as brief as possible, sir.
Right.
So basically, why is it important that any drug in COVID which has been studied with respect to the oxygenation, and COVID predominantly affects the parenchyma and the interstitium. The first sign there is interstitial involvement, or there is a reason to worry, will be a 6-minute walk test. If any patient comes to your OPD in the first 7 days, patient has finished 6 days of symptoms at home, and coming after 6 days of therapy, there is a subset of population in the initial time who has persistent fever, dry cough, and there is only exertional desaturation. So the Indian ICMR and the Ministry of Health Family Welfare guidelines have now also included systemic steroids as well as inhaled steroids. Systemic oral steroids can also be given in an early stage in this one particular subset of population where there is significant 6-minute walk test desaturation. And also with respect to fibrosis cases after a month of discharge, if a patient has 6-minute walk desaturation, again some role of steroids in such cases, or any anti-inflammatory therapy. Even the inhaled steroid, the STOIC trial has shown that inhaled steroids for patients above the age of 50 is recommended in a very small subset of population. And again, 6-minute walk test will help to identify these subsets of population. Thank you, sir.
Okay. There are some short questions which we'll discuss later on, because I can see impatience on the face of all neurologists. But one question is there: what are indicators of fibrosis like high IL-6 or high D-dimer? No, probably LDH is only one which suggests necrosis, and therefore LDH may be of some clue, but otherwise no there. We are going to the last case, and that is for our neurologist. 47-year-old male, hypertensive, on amlodipine, RT-PCR positive on 5th April. On 19th April, the patient presented with facial weakness, failure to close right eye, no limb involvement, and some physicians started acyclovir. Worsening of facial weakness with bilateral involvement later on, gait was involved, change in voice with lower limb radiculopathy, there was no fever. Vitals were okay, bilateral LM facial, proximal muscular weakness in lower limb with posterior column involvement, walking with support. Potassium okay, MRI brain okay, HIV negative, CPK 46, EMG NCS demyelinating sensory motor polyradicular neuropathy, CSF protein high, so dissociation clearly seen, WBC 0, high COVID antibodies. Vitals were okay, bilateral LM facial, that we already seen. Patient was given IVIG 0.4 gram per kg per day for 5 days. Discharge, walking without support, bilateral facial weakness persisted. But on 6th May, patient came back. He cannot stand without support. Upper limb weakness is now there, 3/5. Bilateral LM facial weakness persists. Lower limb weakness has worsened with involvement of ankle from hip. So now we'll go to our neurologist. What is this? Number one, how common is it? And if there is recurrence or worsening, how will we treat it?
Yes, sir. Thank you.
Looks relaxed.
Long wait. So, sir, COVID, after the lungs, the CNS is the most common involved system. That is beyond doubt. And in CNS also, just like any virus, it affects the multi-system involvement. and that is the you may call the beauty of presentation, or you may call the sad state of affairs, that we are seeing varied number of presentations. In central nervous system, we see the strokes most common, and in peripheral nervous system, the Guillain-Barré syndrome are most common. Of course, this I'm talking about serious illnesses. We of course see non-specific illness like headache, cranial nerve palsies, and all that. But serious illnesses, mein GBS is one of the most serious illness secondary to COVID infection. Now, what I have observed in last 1 year, that COVID usually the GBS presentation which starts, it is after 5 to 15 days after the illness. Second, what a striking feature what I've noticed is that the COVID per se, the severity of COVID is less in patients of GBS. That if you see they are less hypoxic, they are less requiring oxygen support, or their inflammatory markers are not so high. So primarily, it is just usually it is a predominant manifestation, isolated CNS manifestation rather than a lung manifestation. Sir, this the case what you presented is a classical presentation of Guillain-Barré syndrome, which can happen post-vaccination also. Now we know with a strong case reports and strong evidence that it is happening post-vaccination and post-viral fever. This is nothing new. It has been proven for more than 100 years now that post-viral illness and post-vaccination Guillain-Barré syndrome is known, especially in children and even in adults. Now, the very striking point is that this patient had a second after improvement, the patient had a deterioration. Now, this is not very commonly seen. This is sometimes a patient of AIDP, that is GBS going towards the CIDP patient presentation like that. So this is a rare presentation, and in COVID also it is a rare presentation. We may have to rule out associated muscle involvement or rhabdomyolysis or something prolonged steroid use in such patients. And if it is not there, then we have to investigate for CIDP. Now here again, if there is no involvement of respiratory muscles, I would not like to give a second trial of IVIG. Here we'll give just like a CIDP. What we give steroids and steroid sparing agents.
Fine. One more question about neurological complications. Now we'll be taking very short and brief answers because we have to finish in next 20 minutes. Post COVID-19 headache, how frequent? It is not a new onset headache. The headache which persists for about 6 weeks post COVID. How would you manage in short?
Yes, sir. Here there are three main types of headache. First, just briefly, sir, we differentiate between a primary headache and a secondary headache. Yeah. So secondary, of course, we have to rule out a sinus involvement or a skull-based osteomyelitis, which is very common secondary to after COVID. Once we are talking about primary headache, now patients who are always also prone to migraine or tension type headache disorders, they have more headaches, and there is aggravation. There is definitely seen that they have more headaches. We see such patients in our OPD. Number one. Number two, there is something called as PTSD, post-traumatic stress disorder. Now, this is one of the important cause of headache, as well as associated psychological comorbid conditions, which causes anxiety and depression. Now, here what I want to write is that we have to, if there is an underlying tension type headache or migraine, we attribute them and we associate, we give a treatment associated with that. But here, SSRIs and tricyclic antidepressants, that will be my drug of choice to manage headaches after a post-COVID syndrome.
Coming to one more question to you, post-COVID asthenia or fatigue.
Yes.
How would you manage?
Sir, post-COVID asthenia, more than 50% patients complain. This is prolonged more than 12 weeks also. Now, if it is something like a fibromyalgia-like syndrome, exactly not a fibromyalgia syndrome. Here, I have a good experience with drugs like duloxetine, SNRI drugs, which will help in your fatigue as well as it will help in your non-specific myalgia and muscle ache.
Fine. Thanks for very brief answers. Couple of questions to Dr. Kalpesh and Dr. Neil. Dr. Kalpesh, these days we are seeing lots of eosinopenia persisting and lymphopenia persisting post-COVID for about 8 weeks or 12 weeks, despite the fact that patient is off steroids. Have you seen it?
Honestly speaking, I have seen very few patients of that eosinopenia and lymphopenia. Don't know exactly the cause of that. Maybe the course of steroids leading to hospitalization, or that could be the reason, or maybe due to some other reason also. But I don't know what is the exact reason behind that, the eosinopenia and lymphopenia.
Dr. Neil, your views?
So, sir, this one parameter which was very much studied during the entire, like you mentioned in your case also, there was the neutrophil lymphocyte ratio. So, in COVID in general, when we prognosticate patients, it has been validated among smaller observation studies that neutrophil lymphocyte ratio is a very important parameter. Again, what it indicates is to some extent predominant neutrophils and lymphopenia. If a neutrophil lymphocyte ratio is more than 3.3, that has been the landmark where we say that this patient might proceed toward more moderate to severe disease. So again, lymphopenia post-COVID has been seen either with more inflammation happening during the COVID illness itself, or there is a development of a secondary infection. So rather than being the lymphocytes which are lesser in the systemic circulation, it is the predominance of the neutrophils which is there causing either less number of eosinophils or less number of lymphocytes. That is the reason, because of the inflammation, because of the secondary infections, that sometimes there is a low number of lymphocytes, also contributing to the less immunity to the patients later on.
Coming to Dr. Kalpesh again, post COVID-19 coughing, dry coughing, nuisance persisting for a long time, harassing the patient at night. Very briefly, how would you treat it? We don't go into infection, but
Yes.
just the treatment of that very irritating cough.
Very irritating cough. Yes, many these kind of patients we are treating, sir, with inhaled budesonide along with other cough remedies. We are using for routine BPLD patients before COVID era. Because in ILD, cough is the main culprit even after giving steroids and antifibrotics. So cough is the main predominant symptom of ILD patient, and same thing in post-COVID patients. Many patients are complaining of dry cough persistent. So in that case, to rule out that infection also before prescribing budesonide. And along with that, we can give him supportive remedies which we are using routine in our practice.
Fine. Okay. Coming to Dr. Neil, pulmonary rehab has a huge role to play in post-COVID syndrome. Just 3-4 sentences. Which sort of exercise, pulmonary exercise, would you recommend to a patient who is at home, who cannot reach the hospital, but he has little bit of breathing problem? How would you rehabilitate him on phone?
So again, with this our discussion entire beyond the antifibrotics, I think for post-COVID lung disease, post-COVID ILD, post-COVID myopathy, whatever respiratory issues patient has, rehabilitation has a much more major role than any of the drugs involved. So if the patient has good nutrition, rehab is not only exercise, good nutrition, high protein diet, regular counseling of the patient with the treating general physician or family physician, the regular good exercises that could include deep breathing exercises as well as incentive spirometry with 3 balls or 1 ball, single ball, whichever incentive spirometry the patient is using. Now, it is important that the patient is taught properly with respect to using the incentive spirometer. Number 2, he has to use it more often and he has to record his data. So this might involving a physiotherapist along with your consultation, or you yourself also trace that the patient is following up with physiotherapy. So it is not the drugs alone. Rehab is a major important factor in recovery of these patients.
We can hand over a PEFR to him, which is absolutely portable, just like blood pressure instrument. So have an objective assessment which can help him. Okay, one more question. Before starting antifibrotic in any patient, would you always like to go for pulmonary angiography? Rule out thrombosis. Dr. Kalpesh first and Dr. Neil then. Very short, very brief. We have few more questions.
For starting antifibrotic or antithrombotic?
Antifibrotic.
I don't. There is no need for CT pulmonary angiography in each and every patient before starting antifibrotic.
Dr. Neil.
Sir, no need for any antifibrotic. We don't need a pulmonary angiography in any way, COVID or non-COVID, for any patient for determining any sort of some cases for anticoagulation when there is a very high suspicion in critically ill patients. That is where there is a subset where we would want, suppose echo is not available or we've done the echo, there is a high suspicion. Patient can be moved to the CT department, has a normal renal profile. In those cases, to document if there is a major thrombus, that is where we would have a CT pulmonary angiography. Otherwise, for anti-fibrotic decision, there is no role for CT unless for research. Because for research, again, one of the factors for determining the etiology of fibrosis is the vascular one, the endotheliitis. So probably for research purposes, for a trial or something, we might have stable patients undergo that. Otherwise, there is no definitive rule.
For Dr. Manan, there's a question. 30 years young male, 30, young
Yes,
male, post-COVID case presenting with tingling and numbness of hands and desaturating on 6 minutes walk. CT thorax shows minimal lung lesion after resolution. Echo is normal.
no, I didn't understand the question. For
Tingling numbness of the
where?
hands.
Okay, both the hands. Okay. So, sir, that can be definitely the initial symptom of a nerve involvement. Tingling, of course, it is a sensory part of the nerve involvement. Now, here it can be non-specific, or it can be as serious as a Guillain-Barré syndrome, developing into a Guillain-Barré syndrome. Sir, tingling can be because of cervical myelitis also, where the patient is not able to explain that what exactly he's having. But of course, it is always by examination how to be differentiated between a myelitis involvement or a nerve involvement. Many times I have seen patients of prolonged IV cannula line, where there is injury to the median nerve or injury at the elbow to the ulnar nerve also. So at that time also, but that will be a localized tingling numbness in following the nerve distribution. Here I would like to examine the reflexes and the power of such patient and then decide the further line of management.
There's a side question, nothing related to COVID. Just
Yes,
give in brief. Tingling numbness means vitamin B12 deficiency and injectable vitamin B12. How often this is true?
Sir, usually I don't get a B12 without any motor deficit or a posterior column deficit. I don't get B12 checked because the cost of B12 test is much higher than the treatment of B12. So in vegetarians, I empirically start B12.
Coming to very short questions because we are at the end of our seminar. So one question that we forgot, Dr. Kalpesh, duration of antifibrotic treatment. How much long will you continue?
Up to 3 months, and then we can reassess whether this patient is going into the progressive lung fibrosis or any permanent changes which is not reversible. So I think initial experience from our fellow colleagues and other studies showing that initial 3-month period of antifibrotic agent is beneficial. Later on, we can decide on case by case whether this patient requires long-term or up to 1 year antifibrotics or not.
Dr. Neil, a question. For antifibrotic drug, it is all or none law. Either you give in full doses or don't give. Is it true?
Definitely true, sir. It is whatever has been recently, like this is especially for pirfenidone, that whenever we are using, we have to use it aggressively. There is always that doctor bias. There is also the patient bias. That when we want to see the patient compliance, कि यार ज़्यादा dose में दे दिया तो patient को ऐसे side effect होगा, gastritis होगा. So you counsel the patient when we are starting that you are going to have these problems. Eventually, as per your weight, this is the dose we have to give you. So it is whatever trials based proven in ascent capacity impulses, all trials, it is dose based. So if you are not giving a maximum dose, you are not giving the full therapy. So it is very important. You assess for side effects, you assess for the hepatotoxicity, you assess for the gastritis, you treat it. Or if the patient has liver issues, then you stop the drug completely. But there is no point keep giving it in a half dose or a low dose. That would be it.
One more question, which I think we have already covered. Nintedanib with anticoagulants. Any choice for anticoagulant? Drug interaction between the two, Dr. Neil.
Sir, again, this is from nintedanib has been shown. This is the paper which was published was an observational study with an expert opinion panel in Lancet Respiratory in March. So what it said was that nintedanib, when used with a therapeutic dose of any form of anticoagulation, not per se low molecular weight heparin or dalteparin, but it carries an increased risk of bleeding. So when we are, this is just as a background caution that when we are thinking of a patient of a pulmonary embolism with severe COVID, then in such cases, we have to have either we give it with caution that we have to explain the patient that there might be a drug interaction and you might have a risk of bleeding. So, or if we are giving कुछ anticoagulation के साथ nintedanib we have to give, then we use something where we can quantify the bleeding risk. So again, warfarin would have some role here with a patient with pulmonary embolism with ILD. When we are using nintedanib, use a drug which can quantify the bleeding risk profile. No, newer oral anticoagulant agents will not be able to estimate the risk of bleeding directly that way.
Last two questions for all three speakers, and that is the most anticipated questions. Obviously, very brief answers. Will third wave come? Dr. Kalpesh, then Dr. Neil, and then Dr. Manan.
Yes, definitely, sir.
Dr. Neil. Dr. Neil.
Sir, third wave will definitely come, but the magnitude and the severity, that is something which the wave is definitely, it has started. If we look at the World Health Organization data yesterday or day before, it is showing that the decline has stopped in most of the countries, not only in India, in all other Southeast Asia, Europe, the decline after the second wave has stopped. And in some countries, it has started increasing already. So the wave is definitely coming, but it is going to be how much magnitude and how much severe it is going to be. It is definitely going to come.
Dr. Manan.
Sir, we hope and pray that we don't ask this question for the fourth wave. No fourth wave, no fifth wave. Only third wave, as we are seeing some cases increasing. But I think probably we will not be in such deep trouble when it's compared to the medical services. Hopefully, sir. Fingers crossed.
One more question, and that is the last question to all of you.
Just one question for you, sir, and Dr. Manan Mehta, that if we have not discussed in the entire discussion regarding antiplatelets. So this just one case, a 50-year-old male, this is an actual case which we've treated with normal D-dimers during hospitalization, had moderate COVID pneumonia, did not require oxygen for a couple of days initially, was discharged. This patient had a normal D-dimer throughout, this was part of the first wave, was not given any anticoagulation at home. 2 weeks later, this patient presented with severe headache, and on the imaging was found to have a venous sinus thrombosis. Now, this is a patient, this is just a small example case because this happened in one of the cases. So to both of you, sir, that if there is, what is the role of any antiplatelets? And if at all there, then in which subgroup do we have to think about using antiplatelets?
Dr. Manan first.
Sir, yes. So, were there any risk factors of developing hypercoagulation apart from COVID? With
the patient was a 50-year-old male, diabetic and hypertensive, nothing else.
Yes. Yeah. So, sir, exactly may not be directly attributed to COVID as of now. Yes, definitely COVID was a precipitating factor. But before COVID also we see CVT very commonly, and especially in vegetarians where there is high homocysteine levels and dehydration. Of course, the etiology part. So D-dimer is not the direct cause of thrombosis, as we have proven again and again. Regarding antiplatelet, now the thing is that it is more of a endothelial dysfunction causing a procoagulant and prothrombotic state with a cascade of complement activation. So here the antiplatelet role would be not, it is more of a placebo for doctors. There is less bleeding risk and we are giving something. But to be honest, antiplatelet has no role in preventing a thrombosis per se.
Agreed. So my take would be the same. The indication of antiplatelet agents post-COVID are same as if patient does not have COVID. Otherwise, COVID itself, there is no indication of aspirin. Forget about clopidogrel. And the last question, before I go to last question, thanks all speakers. You really did a wonderful job. Thank you very much. And thanks the company. My last question is, what do you think would be the drug of choice once the third wave starts? Which drug would dictate, antibodies or remdesivir? Dr. Kalpesh.
I think remdesivir, yes, is the answer because the cocktail antibody is not effective against the Delta plus risk, as the study shows. So apart from remdesivir, other new molecules are also available, like that 2DG sachets are available now, freely available, and that pegylated interferon alpha is available. And the study is showing that it is a stronger antiviral than remdesivir.
The question is, which drug would dictate the third wave?
Remdesivir.
Dr. Neil.
Sir, again, frank answer would be neither. Again, because remdesivir per se, from whatever published evidence, the solidarity trial. The only positive trial was ACTT1, and that trial which indicated some benefit, and especially with the duration of using remdesivir. Majority of the big randomized control trials, meta-analysis, in all of that, they have not found it to be changing the outcome. Monoclonal antibodies in some specific subsets with mild disease, but again, when we look at the overall patient with the cost as well as with the indication, so remdesivir, if at all we are using with a combination, now what recent studies are studying, that remdesivir with an immunomodulator like baricitinib or other immunomodulators might help in changing the game, but at the end of the day, it is going to be the entire array of drugs as well as the patient profile which is going to change it actually, not a single drug.
Dr. Manan.
Sir, actually studies, sir, ask any of your panelists or your delegate who will not use remdesivir in any of the patient.
So Dr. Manan, it is always, this is for the first time in COVID that evidence versus experience when strikes. India has started believing that we have more experience than US's evidences.
Absolutely. So the trial where remdesivir did not show mortality benefit, now those trials were in patients who are intubated or severely affected COVID patients. Now, see here, as any antiviral, if you have Bell's palsy or if you have herpes virus infection, it is indicated that within 72 hours you start an antiviral drug to prevent the viral replication. So steroid, a simple take a Bell's palsy case, we give antiviral, we give steroids. Similarly, for any viral infection, per se COVID, we want to halt the viral replication, number one, and we want to control the inflammatory state, number two, which we control it by steroids. Now, giving a remdesivir is everyone, sir, early use of remdesivir, judicious use of steroid, and indicated use of anticoagulation. That is the way to go, and it is going to remain the same even in the third wave also.
Okay, so as I said, there are 3 E's: evidence-based medicine, experience-based medicine, and expectation-based medicine, where probably remdesivir comes in experience and expectation rather than evidence. And despite all said and done, most of the people used it. And the whole reason of using remdesivir was probably Indian doctors, all of us, believe that our experience is much more than the evidence is presented by the Western countries. I think that's where we'll stop. Once again, thank you all of you. We had a very nice discussion, and I'll hand over back to Hetero people.
Thank you, sir.
Thank you very much, Doctor. It was indeed a very informative session for our viewers. I thank Dr. Urman Dhruv and the entire panelists, Dr. Kalpesh Panchal, Dr. Neil Thakkar, and Dr. Manan Mehta. So that is all about today's webinar. Stay healthy, stay safe.
Good day, and thanks everybody.
Thank you. Good night, sir. Good night.
Good night.
Thank you very much, Doctor.
Good night.